Colleen Hutchinson, and we are here at the 18th Annual Minimally Invasive Surgery Symposium at the Wynn Encore Las Vegas. I have with me today Leena Khaitan. Leena, it's great to have you here. Can you just take a couple of minutes and introduce yourself?
Sure. Well, Colleen, thank you so much for having me. It's really a privilege to get to talk to you and be with you here this morning. My name is Leena Khaitan, and I am at University Hospitals in Cleveland, Ohio, and I direct the bariatric surgery program there in our esophageal and swallowing center. And privileged to be here at MISS and talk during the foregut session and the bariatric session this week.
Yeah, along those same lines, I wanted to just touch on that ACS Women in Surgery Committee and Association of Women Surgeons gender salary equity statement.
Right.
So that came out, I think, in August 2017, and I'd like to just get your opinion on it and how you think, do you think that it's going to be effective?
Sure. Well, money's always a loaded question, right? And nobody ever really wants to talk about money, but I think that the data is what the data is.
Yeah.
And I think with all the movements that there have been this past year for women and empowering women, I think that it gives people some license to say this is the data, and we all work in the same work environment. We take care of the same patients, face the same challenges every day, and so that those should be addressed at every institution, and people should be thinking about it rather than just brushing it under the rug. I think it's been brushed under the rug for a long time.
Yeah.
So I think through knowledge is power, and so now that we are aware of this data, hopefully we can see some change going forward.
Well, and hopefully in the absence of mentorship, which you touched on earlier, something like this helps, and having connection and partnership between an association like the American College of Surgeons and an advocacy group like AWS will really help things.
Absolutely, absolutely.
I wanted to follow up on your presentation topics, which are related, treating GERD in the obese and also managing reflux in post-sleeve patients. Can you just tell us a little bit about them?
Sure. So, GERD and obesity, I mean, what a challenge in America today, and obesity is growing, GERD is growing, and probably they go hand in hand.
Yeah.
I mean, I think that we all agree on that, and probably one of the biggest changes I've seen in my lifetime through my career is that weight loss surgery, particularly a gastric bypass, has become the management procedure for GERD in the obese patient. And, when we first started doing anti-reflux surgery in the late 90s, early 2000s, that was not the thinking. And so I'm going to share some of that through my talk on GERD in the obese and how we have to manage that, because thinking of weight loss surgery as part of the anti-reflux armamentarium is still something that's lost on insurers in a lot of places. So I'll see a lot of patients who have bariatrics as an exclusion on their policy, but the main reason they're seeing me is for reflux, and so that has really been a challenge. So so I hope to touch on some of that, and then reflux after the sleeve has really become one of its own fields.
Yes.
I mean, we have essentially created a new field. The old thinking was that well, at least you lost weight, and the reflux is a very secondary problem. But I think now we know reflux really affects people's quality of life.
Yeah.
And a lot of the reason weight loss surgery helps people's health, but it also helps improve their quality of life. And then if they're miserable and they're refluxing every day, that's an issue. So we have a lot of new strategies to address that, a lot of new technologies available to us, and I think that it also provides opportunity for us to think about how we're making sleeves too, because if you talk to 50 surgeons about how they do a sleeve gastrectomy, the concepts are all the same. And I think we all believe the same things, but the way we actually do it is a little bit different. Yeah. Everybody brings their own nuance to the table. Well, in my experience, I saw this, so I fire my stapler in this direction and not in that direction. Or, everybody uses a sizing device. Everybody talks about the shape that it should look like, but the ultimate where it ends up there's a lot of variability. So I think there's opportunity for improvement there.
So maybe some more standardization and cutting down on variability, as
Absolutely.
well as maybe a little bit more work in terms of patient selection.
Yes.
Will bring those numbers down.
Absolutely.
Yeah.
Absolutely.
Well, thank you, Leena, for being here today.
Thanks, Colleen. Appreciate the opportunity.